Terus ke?
Dah record. Betul tak? Dah sudah sama.
Guys, dengar tak suara? Dengar tak suara?
Okay, Assalamualaikum warahmatullahi wabarakatuh. Okay, so there's about 13 of you and there's not 13. Berapa orang sepatutnya dalam ni? I thought it should be 10. Okay, doesn't matter anyway.
Doktor, ada yang join. Belum
Okay,
lagi.
that's fine, doesn't matter. Okay. Alright, so we're going to start with umur kita lepas ya.
Wait, ada.
Okay. So basically, this is the challenge of doing online teaching for clinical punya phase. It's not the best way to teach a long case presentation, but this is what we got for the time being. I'm not so sure really when exactly you guys going to start apa tu kita panggil apa face to face teaching. Have you got the dates already?
Yes, next week.
Next week. Next week mean that you guys will be seeing patient, directly, not mana tak buat lagi simulated kind of teaching. Okay, that's fine. So this is probably the last session long case online aku. Kalau dah next week korang dah buat ni. Anyway, so you guys are now in the campus.
Yes.
Okay, some of you still outside the campus.
No.
Semua in the campus. Okay, that's fine. So but obviously it's a time that all of us has successfully increased our BMIs because of the Raya Korban and not doing so much in terms of exercise. And hopefully by going to the campus, you guys can reduce back your BMIs in terms of healthy BMI. Okay, fine. So I've given a slide to one of your reps last week. Afiq and Aidan, and I give it to you. So there's two cases that I give to you guys for kind of leading the case. So you guys need to lead the case as if that you are doing the long case with the patient. And then your colleague will add on in terms of you can ask your colleague questions. You can ask your colleague things that you expect in terms of infection diagnosis, expected investigation to be done, and also your colleague also can ask you questions that is suitable and also appropriate to be asked as well. So there's two cases. So I'm going to leave to the person responsible to read the cases, and this is your floor. Okay. Okay.
Along the discussion, can we ask you too, or at end of the discussion we ask you?
Okay. Yeah, you can ask me questions as long as it's not a personal question. That's fine.
Okay. Should I share the screen?
Okay, you can. You still sharing your face? Okay, now you're sharing yours. Okay, fine, great.
Saya nak tukar ni. Okay,
Oh,
can you guys see? Yes. Right.
Okay, oh, yes. Very happy voice.
Okay. So for the first case, your 2-year-old boy is referred to the pediatric D unit by his GP with a history of fever, cough, blood runny nose, and sticky eyes for 6 days. His GP prescribed amoxicillin 2 days ago for cytis media, and that evening he had started to develop a rash around his ears and hairlines. His parents stopped giving the antibiotics, but the rash continued to spread over most of his body. The parents report that he has been very miserable and lethargic for the last 5 days. They thought the rash might be an allergic reaction to the amoxicillin. He attends nursery, but his parents are not aware any of the other children who have been unwell. His parents are well, and he has an older brother who has autism. So let me just put it into timeline. So 6 days ago, before his current presentation to the hospital, he had fever, cough, blocked runny nose, and sticky eyes. And then 5 days ago, he started to have miserable and lethargy. Then 2 days ago, he been diagnosed with otitis media and been given amoxicillin. And on the same day, he started to develop rash around the ears and hairline. And although the amoxicillin has been stopped, the rash still spread over the body. The parents unaware if there is any sick contact, and he has older brother who has autism. Is that clear, everyone? Yes. All right, that's okay. So based on this case, do you have any what further questions that you want to ask that may want to ask at one? What further question?
Abang, does his brother also have the visit on him? Sambung. And also
Yes.
about his is he the only one that has the rash, or does his brother also has the rash?
Oh, okay. Okay. Why do you want to ask that? Could be infected by the brother. Yes.
Yes.
Okay.
Maybe it's infection.
All right. Okay. What about the rash? Adha, do you want to ask anything about the rash?
Yes. I would like to ask about the characteristic of the rash, and then
Okay.
I would like to ask about spreading of the rash, and then is the rash comes with stages, and is it irritable, blanching or non-blanching? Because it gives significance now, whether it's a hemorrhagic rash or an allergic rash.
Okay. What are the what are the diagnoses that you might be thinking of about the rash?
I think maybe measles, maybe scarlet fever, and other viral infection,
Okay.
such as erythema infectious, HSP. But it depends on the types of, characteristic of the rash.
Okay. All right. So does anyone want to share something about the difference of rashes in this the mentioned disease? Anyone? Okay. So this is 2 years old boy. So what is the most you think of the most yang paling dekat differential diagnosis that we think of? 2 years old boy with rash.
I think it's a roseola infantum, because in roseola infantum, it is prominently happens in 2 years old children at a peak age, and then they have high fever before the appearance of rash, and with the appearance of rash, there will be some infections such as otitis media, and this patient have otitis media, and other infections like rhinorrhea, sign of infection rhinorrhea, coughing, and then upon intake of antibiotics, the rash become precipitated, and people might mistaken it with drug allergies.
Okay, so so how would you differentiate between allergic rash and this kind of rash? Adha.
In allergic rash, it should be irritative, should be itchy. But in this rash, it is a maculopapular rash. It comes with bump and also some flat lesion, mix of bump and flat lesion, and it appears after fever.
No. Okay. Okay. Then other than roseola, anyone mention about measles? There's how about measles rash? Anyone?
Yes, maybe.
Yes. Yes, Aina.
Yes. One of the DDS might be measles.
Okay, measles. So can you describe the rash of measles? How can we can we differentiate it with roseola?
Measles is maculopapular rash, if I'm not mistaken. Okay.
Yes. And the rash will spread downwards from behind the ears to the whole part of the body. Yeah, it's correct. Good, Aina, good.
Okay.
Measles has prodrome.
Okay, so what is prodrome, Aina?
Prodrome is there are like signs that the patient will have before the appearance of exanthum. In measles, it comes with Koplik spot, erythematous space with a whitish spot, and 3C, coryza, cough, and conjunctivitis. The type of rashes comes from below the ear and spread to the trunk.
Alright. So we might be thinking of measles for this case too, right? Then other than that, we also do you think of scarlet fever? What do you think? Maula?
For scarlet fever, the rash starts from the head below the ear to the neck, and then to the body and arms and legs.
Okay. 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 So what causes scarlet fever?
Usually bacterial infection, group A, beta hemolytic streptococcus.
Okay. Alright. So do you think this could be a differential diagnosis for this case?
Yes, because he developed rash from ears first and
Okay.
hairline.
Alright. Okay. Then scarlet fever, we have roseola, measles, scarlet fever. Other than that, anyone want to add? Anyone? Afiq?
Okay, I may be thinking about other than blanching rash. For example, blanching rash. Just our tips said just now. Maybe a patient may have some kind of HSP or any other
Hemorrhagic rash.
hematological problems.
Right.
Because,
Okay, so
but
in
we need to
history,
confirm the characteristic.
okay. So in history, what question that we want to ask to know about the hemorrhagic rash, if there is any?
Any family history of hematological disorder?
Okay, any family history?
Any gum bleeding?
Spontaneous bleeding, right?
Spontaneous bleeding. Easy bruising.
Right. Okay. And how about Kawasaki disease? Do you think I can include Kawasaki disease in this case? Okay, Awati.
I don't think so. Sorry, after it.
Okay, Zata. Okay, Zata,
Sorry,
can
sorry.
why do you don't think so?
I think because there is because there is no fever, right? For 5 days, for more than 5 days.
Fever for six days ago. But I was
Is that fever?
I was unsure. I was unsure if the fever still continue until
Oh, sorry.
the pregnancy. Okay. So
The
Kawasaki disease presented how is it presented?
So basically, the diagnosis of Kawasaki based on fever of more than 5 days and conjunctivitis, rashes, extremities, swollen, and then mucosal membrane, something related to mucosal membrane. I don't remember.
Good, that's good. You want to add anything? Awati?
Okay, for the rash in Kawasaki disease, usually truncal and usually non-vascular. There is also cervical lymphadenopathy and conjunctivitis.
Okay, it also has strawberry tongue, right? Okay, so Kawasaki disease. Okay, so what kita ada lima kan? We have already measles, scarlet fever, roseola, Kawasaki disease, hemorrhagic.
Any
So yes,
about the concern of the parents regarding reaction towards amoxicillin. Is it because his brother having allergic to antibiotics?
oh, we can ask that in the history, right?
Yeah.
We should ask that. Okay, if the brother has allergic reaction to amoxicillin or not. Okay, we should ask that in history. Then, what any history that you want to ask? How about vaccination history? Do you think it is important?
Yes.
Okay, why? Okay, why is it important? Anyone?
I think because if patient has not complete the vaccination according to schedule, it may not give full protection to the patient and patient can have infection, especially the MMR vaccine.
Yeah, so we need to ask about we need to ask about the vaccination history. And then we also need to know about rash the vaccination history. Other than that, what history that you think we should ask more? Okay, to get our working diagnosis.
How about eczema?
Okay, eczema. How is it related?
Any atopy?
Oh, okay.
But
Okay, but what you want to say? Hello? Okay. Feeding history, do you think it is important, and why we need to ask feeding history? Okay, why it is important we need to ask about the feeding history? Azaki? Faiz? Faiz ada? Faiz? Okay, tak apalah. Okay, so feeding history, we can ask about the feeding history because the patient is still at 2 years old age, right? So basically, a mother breast milk still can give antibody to the baby if if the baby get full fully protection from the breast milk. Okay. What else you want to ask? Do you want to ask? Okay. Is there anything you want to ask more about the history? Adha, do you want to add anything?
I think we can ask about during the mother's pregnancy, does he have any infections going on, such as in touch infection? Yeah, because in touch infection, there will be rash, and some of the diseases that transplacentally transmitted to the baby, they will also get the same rash. So, and also they can get a lot of abnormalities. So, touch infection, and then
But this is a boy with a 2 years old boy. It's not really a newborn, newborn
congenital.
disease. Yeah.
Okay. Okay, so tak penting sangat. Okay.
Okay. Okay. I think that's all for history. Okay. So for the Doctor, should I proceed with the investigation or examination?
All right. So let me just recap it again. So far in terms of your history taking, so you have the list of differential diagnosis that you got so far is the scarlet fever. Scarlet fever, and then you got the Rosella.
Rosella.
Rosella apa nama? Infantum. But you guys thinking about rubella? Okay, apa lagi?
Measles.
Measles, okay. So you okay, and also Kawasaki, and so you got 5 things there from your history taking, okay. So that's a lot lah. For I think that's enough lah to think about those 5 things. Obviously, the more different diagnosis that you have, you will get more questions you want to ask. Okay. The most important thing in this case, in this history, was obviously the duration of fever. So the duration of fever was 6 days. And so dia kata history of fever, cough, blocked nose, and also sticky eyes for 6 days. Okay. So and then the case kind of like drawing you down to concentrate on the rash. So that's the main thing about this presentation by the parents. So the rash. So you want to know the characteristic of the rash. So you guys have been asking about basically about maculopapular rash, itchiness, apa lagi? Pain, blanching, no. Okay. In terms of rash, the most obviously the characteristic of the rash is important because it gives you an idea what could be the diagnosis. But if if I got you guys as a medical officers overnight, calling me the specialist on call like 4 o'clock in the morning. Okay, so the most important thing, what is the question that I will ask you that will make me worry or being relaxed about this case with the rush? What is the one single question that I will ask you whether I will be worried or not about this kid?
Either the patient septic or not.
Okay, so septic or not. So what kind of question you want to ask about septic or not? We're talking about the rash. Talking about the rash, okay? Apa? Main bisik-bisik memang tak dengar lah bisik-bisik. Yeah. So what will be the one question that I will ask you, because that question will determine whether this child is going to go to ICU or can this child go to just a normal ward.
Size of the rash.
The size of the rash is not that
Pain?
important. Sorry?
Pain?
Painful rash. Okay, not really. Somebody talking about septic. What is the association or rash characteristic that is associating with sepsis?
Tachycardia.
Okay, so yeah, kind of hemorrhagic. Tapi the question, the term that we normally use,
blood spot.
the term that we use is the non-blanching rash, and regardless whether the rash is a so kalau dia non-blanching, okay, normally we use the words petechiae or purpura, kan? Okay, so the words petechiae macam mana? Dia pinpoint rash yang small kan. Kalau purpura is more very big rash, but both are non-blanching rash. Okay, so when you guys say macula papula is not really for me. Macula is just a rash that sounds in terms of technicality of macula papula would be blanching rash. But if you guys say petechiae or you say purpura ataupun purpuric rash, my first thing that I would tell you is get the child antibiotic straight away. What is the septic parameter dia? Dia punya BP macam mana, heart rate macam mana? Because if you got somebody who are septic presented with non-blanching rash, because you expect this child is going to be very sick that require intensive care. So that's why my next question would be, what's the BP, what's the heart rate, what's the temperature? Okay, and what's the conscious level? Kalau dia drop conscious, dia punya GCSA drop, then you probably want to intubate this child, and then send to ICU for further management. So those are about the rash. So if you're calling me 4 o'clock in the morning, so the next question I will ask you, why is the rash looking? Is it blanching or non-blanching? If it's blanching, that's fine. You probably just can take the child to the normal ward and then observe, and let's see what's the rash doing. Okay, that's one thing. And then the scenario also talking about saying about blocked nose, sticky eyes, and cough. So in that particular case, and with the rush of 6 days, you also want to ask for the question in terms of, is it any other symptoms that parents can notice? So as you guys mentioned about so somebody asking about the characteristic of the rash, where it started, how it spread, and so on. So if you're talking about measles, the pathognomonic measles punya rush spreading was from behind the ears, or the hairlines going to the face and down to the trunk ataupun the whole body. So those are the punya way of the rash spreading from the behind the ears or the hairlines going to the face and down to the trunk or body. So that's very pathognomonic for measles. The same thing with measles. The child looks very irritable or very miserable at times. So selalunya dia tak main, dia merengek sepanjang masa. If you most of the time dia akan menangis atau nak dokong lah most of the time. So it's just the characteristic of a child with measles. They don't really stand still or playing or happily laughing and so on. So most of them are miserable, crying all the time. Okay, so those are characteristics of measles. Compared to rubella tend to be horrible looking. Maknanya nampak macam rasanya macam teruk, tapi they're not that miserable. So they look okay. They still can play. They probably can eat and drink okay. At the same time, if you're talking about Kawasaki also quite miserable as well. So most of the child with Kawasaki, because of the inflammation in the body, they tend to be very irritable and very miserable as well. So Kawasaki and also measles tend to be orang kata cross dia punya features dia kind of mixing a bit. Cuma obviously you need to find out the criteria for Kawasaki. So your colleague mentioned about characteristic of Kawasaki. So there's 5 characteristic of Kawasaki. But the main thing is fever must be more than 5 days. So in this case, the fever is 6 days. So it fits the criteria, but you need to find out what are the criteria that looks like Kawasaki. So in this case, so what is the criteria of Kawasaki? So we know that the fever more than 5 days. Okay, what else?
Conjunctivitis.
Okay, what kind of conjunctivitis are you looking for? It's not just conjunctivitis. There is a specific. It's a specific characteristic of conjunctivitis.
Non-purulent.
So non-purulent conjunctivitis. Okay, so it tends to be just watery eyes. The eyes looks red, but it's just watery. So selalunya kalau orang Melayu dia katanya mata tu ada tahi ke tak, mata tu bertahi kan. So nampak macam sticky eyes kan. So but Kawasaki tend to be just red. Their conjunctivitis is red. However, it's just the watery, not the characteristic of the gunky, mucousy, the sticky eyes that they have. So in this case, it just mentioned about sticky eyes. So it's probably unlikely to be Kawasaki. So conjunctivitis. So the word is non-purulent conjunctivitis. So if you got MCQs ke ataupun PMPs ke ataupun korang punya KFQs kan. So if you ask a question about list the 5 characteristics of Kawasaki disease, then if you put conjunctivitis, then you won't get full marks because you need to mention non-purulent conjunctivitis. Okay, so the wording must be right for you to score the right answer. I don't know the question for KFQ for you guys. That's just for example. I'm not giving you the hint. It's just an example. Okay, so conjunctivitis. So what is the next characteristic of Kawasaki?
Mucosal changes.
So mucosal changes. So mucosal changes, it could be anything. It could be just lips, peeling of the lips. It could be strawberry tongue. It could be tonsillitis. So anything that looks like inflamed looking. So the mouth quite red and inflamed. So those are the features of Kawasaki. So you got the mucosal changes. Okay, next.
Cervical lymphadenopathy.
Okay, so the word here is cervical lymphadenopathies. Okay, if you put lymphadenopathies, it's not going to be the right answers. So you make sure that you put cervical lymphadenopathy because those are the characteristics of Kawasaki. Making sure that parents probably don't really realize that they might have a lymphadenopathy because the lymph node probably just small lymph nodes, not that big. So as part of the Kawasaki assessment, you need to feel the lymph nodes in the cervical region, and then see whether they are big or swollen or not. The swelling can be more than whatever. The characteristic of swollen lymph nodes in children is there is no set size for them. But as long as that, if you can feel them, means that that's quite swollen. But some of the children, especially less than 5 years old, they have persistent lymphadenopathy, but not necessarily mean swollen. So in that particular case, sometimes it's difficult to diagnose lymphadenopathy because most of the child less than 5 years old might already have swollen lymph nodes that's not inflamed. But you need to put things together in context with Kawasaki. So you got lymphadenopathy, you got conjunctivitis, you got mucosal involvement or mucosal inflammation. Okay, so that's 3. So 4 and 5th.
Rash and edema.
Okay, so rash. So rash can be anything.
Polymorphous rash.
So it's mainly polymorphous rash. So it could be small rash, it could be big patchy rash, it could be anything like so. So as long as they got rash, mainly it's the upper trunk rash that you see in Kawasaki. But sometimes in the rare cases you can see all over the body. The rash is all over the body, and then the swelling is mainly the peripheral swelling in terms of the fingers or sometimes if they presented very late, they probably presented with the peeling of the skins of the periphery. So the fingers there swollen initially, and then after the swelling, the skin just peeling. Dia kulit dia macam tercabut kan. So those are the 5 criteria of Kawasaki. And obviously in this age, Kawasaki is quite common as well in this age. So you don't really see Kawasaki like 7, 8, 9 years old. However, there is also apa kita panggil atypical Kawasaki yang mana dia ada 5 days, at least 5 days of fever, tapi the child does not really fit all other criteria in terms of hitting all 5. So sometimes you can put them as atypical Kawasaki as well. Okay, so that's about Kawasaki. Apa lagi? Your differentials. Scarlet fever. Again, scarlet fever is normally it tend to be infectious due to group A streptococcal infection, and it's mainly just rash and also the mucosal involvement, strawberry tongue and so on. It's rarely cause conjunctivitis in scarlet fever. And obviously you're talking about Rosella, so those are the viruses that's quite common in this age. Okay. Why in this case it mentioned about a brother has autism?
Developmental.
Okay. So in what sense you're talking about in developmental in this boy? Because maknanya dia in terms of family history dia, abang dia ada autism kan. So why do you think this particular information is so important that the case put this information in this case for us? What could it be? Adakah dia nak cakap some sort of just whatever non-significant information, ataupun it might give you a bit of background to the illness. So why this information been put in the case? Apa?
Could be caused by
Genetics. So you mean this infection and this rash, this fever is due to genetics?
No.
No.
The cause
what,
of autism.
the cause of autism? Okay, what is the cause of autism?
Infection.
Infection can cause autism.
I mean, infection that can cause the problem. I'm not sure too.
What I mean is why this information is so important to the whole case that we are dealing now. So we know that this child is 2 years old child with 6 days of fever and rash, and then tiba-tiba kenapa this information about brother ada autism? Ada kena-mengena ke dengan kes ni?
Infected from the Bible.
Tapi it says that he attends nursery, but his parents are not aware of any other children that who have been unwell. His parents are well. Maknanya they've not mentioned anything about the brother apart from the brother is autism. So macam tiba-tiba je, tiba-tiba cakap semua orang semua sihat. And tiba-tiba cakap pasal abang ni ada autism. Tak cakap pasal it's not mentioned that the brother is well or not. But the most important question, the most important information they put here is the brother has autism. So does this autism really relate to the situation, to the problem that this boy, 2 years old Ewan, has fever for 6 days?
Autoimmune disorder?
So autism tu autoimmune kan?
No, I mean autism related.
Autism related autoimmune.
Strong relation. I don't know.
So we know that autism is a neurological disorder. It's a neurodevelopmental issues, and it tend to be associated with genetics rather than anything else. So you don't really see a child that was normally okay up until a couple of years, 2-3 years, and then tiba-tiba dia akan ada autism. It's not that particular. We don't really diagnose autism in that way, because normally autism, you can see the symptom and signs from their from kecil lagi lah. Then they develop the symptom and the signs by 2 years old, 3 years old. So you see them like that. You don't see them develop well up to 3 to 4 years. Then tiba-tiba dia ada autism. Autism does not be diagnosed like that. So the autism normally, you see the small signs when they are 18 months, and then by 2 to 3, they got all the signs already, all the sign of autism already. So you don't really see a child yang autism tiba-tiba je autism kan. So I normally, you know, if I see you and tiba-tiba you guys become autism. So you are now 23, 24 and so 21 and lebih kurang. So tiba-tiba autism. It's not like that. So autism is normally come when you are small, or when you are small. You develop that when you are small. Unless you're talking about autism regression. So sometime have a child that was already delayed in terms of speech. There's no eye contact, and then sometime by 3 to 4 years old, they become regress. So from speaking a couple of words, and then they probably not speaking at all after. So those are the autism regression, which is more different compared, which means that they're already autistic, they already show the sign of autistic, but because of some sort of problem ataupun part of the autistic punya spectrum, they regress. So from speaking a couple of words, even though they already delayed, they then tend to be not speaking, or their behaviors become more aggressive, become more autism punya behavior. What I'm going to tell you sebenarnya, the words, the information about brother has autism, if you guys can go back to there's a paper being produced back in 1990s by a researcher called Dr. Wakefield, Wakefield. So this particular doctor has produced a paper, published a journal, association between MMR vaccination to autism. So that's why this information is very important. Basically, you are looking for, does the family are anti-vaxxers or not? Okay, so if the families are anti-vaxxers, then they probably don't take MMR vaccinations. So that's why they put this the information of brother has autism. So that probably imply that if they are anti-vaxxers, then you, 2 years old, probably have not received MMR vaccination. So that's why in this case, your colleague mentioned about whether the vaccination history, immunization history is important or not. Yes, it is important because it could be the reason that we are dealing for the time being is that this child probably has measles, and then dia dapat measles kan. Okay, so those are the thing about this case. Okay, so I'm just going to show you my slide. Sorry, siapa yang present tadi? I can't remember who's presenting. Fatni ni? Bukan Fatni. Fatni ya?
Dah open.
Okay, so tiba ya dua orang itu.
Bateri saya tak ada bateri.
Okay, dah. So let me just try to. So you guys can see my slide, kan?
Yes.
Okay, so this is the information, the examination findings of this case. So he has 38 fever of the temperature of 38.5. So he's still febrile. So 6 days into the illness, he's still febrile. So his heart rate is about 115. The heart respiratory is 20, and the oxygen level is 97% in the air, which is fine. Dia punya weight dia 14 kg, which is 76 ton, which is fine. He looks miserable and lethargic, and you can see the maculopapular erythematous rash. And the word coalescing over his face and neck and torso. Coalescing, basically coalescing ni maknanya dia punya rush dia macam tu. Dapat nampak, you can see the rush distribution dia behind, over the face, on the neck and torso, dia punya chest basically. So those are the meaning the word coalescing. Coalescing basically dia macam bercantum, coalescing kan. Okay, so otherwise, the heart sounds are normal. The cardiac time is 2 seconds, which is fine. There's no respiratory distress. He is coughing, which is okay. Obviously, there is a lot of secretion that you can hear, the most transmitted sound. The abdomen is normal. Kenapa abdomen is? Why is it important in this case to know the abdominal examination are normal? So why do you think it's important to know the abdomen was normal?
There is any hepatosplenomegaly.
So what could that indicate kalau dia ada hepatosplenomegaly?
CMV.
Okay, so is it CMV? CMV common kan?
EBV, doktor.
Oh, okay.
EB.
Yes, EBV. Siapa cakap tu? Very confident voice. So strong voice. So EBV is maknanya if there is a history, kalau examination nampak macam ada hepatomegaly ataupun hepatosplenomegaly, you probably thinking about EBV. Kalau dia ada jaundice lagi, or sometimes thinking about borderline anemia, and then probably EBV is the thing that you need to think about. So we've not talked about EBV at all during our differential diagnosis, do we? I can't remember. Tak ada. Ada ke? Tak ada. So EBV
No.
probably important as well. And sometimes EBV also can cause rash as well, especially if the child been given amoxicillin or penicillin. Okay, so there is a lot of case report about rash associated with antibiotics prescription in EBV vaccine, in EBV illness. So that could be the reason. But in this case, the abdomen is normal. it does not mean that if abnormal is normal ataupun tak ada hepatitis minimum kali, you rule out EBV. It's still it could still be EBV anyway. Cuma yang depends sign them maybe not that prominent at that time. And then his nose is streaming with a lot of discharge lah, maknanya dia ada runny nose, and then there is purulent discharge in the right ears. His pharynx is wrecked, and there is exudative conjunctivitis. So it's very important to know and note in this case that the conjunctiva is ada discharges, ada purulent discharge. So in this case, it's kind of like ruling out Kawasaki. So despite there are 6 days of fever, tapi all other signs, it does not sound like Kawasaki. Okay, sebab dia ada conjunctivitis, tapi conjunctivitis ada exudate, so it's not. Tapi kalau ikutkan pharynx red, ada rash. It's not mentioned about cervical lymphadenopathies. Apa lagi? And then it's not mentioned about swelling of the peripheries ataupun peeling of the skin, which is fine. So in this case, the examination findings basically ruling out Kawasaki. Okay, Kawasaki, you can diagnose by clinical with laboratory support information ataupun mana you look for the CRP, you look for the ESR, you look for the platelet, and platelet sometimes can be raised as part of the inflammatory processes in Kawasaki. Okay, now my question. So those are your differential diagnoses, and you're talking about scarlet, talking about Kawasaki, talking about rubella, measles, Roseella infantum, and so on. Okay. Then my question would be, what would you do in terms of investigation point of view to rule out your differentials? So nak buat apa? Nak hantar apa? Nak hantar test apa?
Antibody titer.
Antibody apa?
IG.
IgM untuk apa?
For antibody for measles.
Okay.
Or
Okay. So if you suspect this is measles, what is the pathognomonic physical findings that you will see?
complete spot.
Okay, so you're looking for the complete spot, okay, which is fine. But let's say your center does not have measles IgM. So what is your other way of detecting measles?
Measles
Viral
allergy.
Macam mana? Siapa Syarifina cakapnya tu?
Measles RNA.
Measles RNA. So I know, but nak buat macam mana tu? How you want to do that?
They can be detected in blood yang dah heparinized tu. Macam through nasopharyngeal aspirates ke.
Okay, so you either take a swab kan, basically kan? You taking a swab, sama ada dia pakai swab dia punya nose ke ataupun swab dia punya mouth dia, apa mucosal dia. So you can send a swab and then send it for PCR, and then you can detect the viruses via that way lah. So it's not a culture, it's more of the PCR viruses PCR punya test untuk test for measles. Okay. And obviously kalau your lab ada buat IgM, then you can send measles IgM. Okay, but if you got complete spots, basically it's a pathognomonic for measles. It's a new vascularization in the mucous membrane in your mouth as part of the pathogenesis of the viruses when you got infected in there. Okay, so that's a test for measles. If you think this is scarlet fever, so what will be your test? What are you going to do for scarlet fever?
Anti-streptomycin.
So you want to do ASOT. Okay. So kalau kata ASOT dia not raised, so is it not scarlet fever? Tengah borak dengan siapa?
Sekejap. Kena tanya. If there is any.
make sure you for Fadlin, if you want your colleague to answer the question, you need to pick the name and then ask them the question. Okay. So jangan cakap anybody can answer the question. So anybody is not going to help you. Okay. You want to if you want somebody to answer for you, you need to pick the name and then ask the question. So, semua buat busy je, buat busy. Macam tak tahu nak jawab apa ni, buat busy lah.
Faiz.
Pak Ais ke Amir ke.
Adha, do you want to answer?
Okay, I try. Maybe I want to look for the ESR as a signs of inflammation for blood culture. Tapi tu tak diagnostic.
So basically, let's say we've done the full blood count, we've done the ESR, you've done the RP, LFTs, you've done the CRP. Okay, those are orang kata apa, basic things lah. So kalau macam full blood count tu, you look for the white cells, you look for the neutrophil count, you look for the lymphocyte count, you look for the platelets, HB, and so on. So those are the blah 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 that is orang kata apa, the basic thing that you guys want to do. But the specific investigation to rule out that particular differential diagnosis that you want to do. So NG-DNAs untuk apa? Untuk Kawasaki? Untuk Scarlet? So Scarlet fever normally have positive anti-DNAs antibodies.
Not sure.
So what caused scarlet fever just now? Tadi your colleague
It
says
is because of group A
Okay.
beta
group A strep. So how are you going to?
Throat swab.
Yes, throat swab. Okay. Combo. It's a combo mind here. Okay. So you want to do the throat swab if you suspect this is scarlet fever, which is fine. Okay. Okay. So that's the thing. Apa lagi orang punya investigation apa tadi? Apa lagi for differential? Can't remember. So EBV say. Okay. So EBVs. So how are you going to diagnose EBVs?
Faiz, you want to answer?
For EBV, I would like to check for 9.
Pak Ais buat apa, dia punya mic dia ada masalah. Okay, Faiz cepat.
EBV serology, doktor.
Okay, EBV serology tak dengar ni. Okay, EBV serology. Or if you normally dekat hospital we don't really do EBV serology lah. You can do it, but normally we go for infectious mononucleosis, which is almost the same thing for EBV lah. Okay, so apa lagi? Differentials. Infantum, Rosia infantum. Nowadays it's a clinical diagnosis. If you really want to send for confirmation, then you can send for serology for herpes type 6 and so on. So but we don't really do them nowadays.
Doktor, I want to ask. Doktor.
Yes.
I want to ask kan, it has been mentioned that roseola rash can occur after giving antibiotic.
Yes. So what orang kata apa, typical roseola normally happen, meaning that the rash dia akan keluar bila fever tu dah nak habis. So those are the typical roseola punya rash. They were saying that the rash can also happen macam EBV punya type lah. So you give antibiotics and the rash came out, but whatever, we don't really believe in that. There's not really any evidence to suggest roseola infantum, if you give antibiotics the rash will come out, because the punya pathogenesis ataupun progression of the rash itself in roseola is, you know that dia ada fever lama dalam 4, 5, 6 days. Then at the end of the fever, bila fever dia dah nak subsided, the rash will come out. So those are dia punya cara dia progress in terms of roseola. So I don't really believe that giving antibiotics the rash will come out, because roseola normally the rash will come out bila the fever dia dah nak habis lah. So it will come out automatically anyway. So I don't think the rash due to the antibiotics. Cuma kalau ABV, sometimes there is a lot of report and case series saying that if you give antibiotics to ABV infection, especially augmentin ke co-amoxiclav ke, so it will come out with rash. Okay, so in this case, what do you think the likely diagnosis from the history and also from the physical examination just now?
Measles.
Okay, so it's going to be measles. The reason for measles is because of the way that the rash started and progressing. So that's the main thing. And obviously, in terms of piece of history that you need to know in this case is vaccination history. Yeah? Okay, that's most important thing. So that's why they are putting the history of brother the other autism is just that try to hook you up with more thorough history to about immunization, about the vaccines. Okay, so if this measles, what is the complication that you expect from measles?
Kalau terlalu lama tu dia boleh jadi ada encephalitis, ada yang lagi satu SSPE, subacute sclerosing encephalitis.
Okay. So dia tak adalah prolong. It doesn't matter whether prolong or not prolong. The measles itself can cause encephalitis. The measles itself can cause SSPE. The thing is, encephalitis, yes, it can happen almost immediately. As soon as you got the measles and the measles viruses goes into your bloodstreams, and after that it travels to your blood-brain barriers and then go into your brain, then you can develop encephalitis from the measles itself. Cuma SSP can happen at any time in your life. So it means that if whether you have mana kalau measles dah resolve, the SSP can happen probably 10 years down the line, 20 years down the line. So SSP, the most scary things about measles is the SSP, because you don't know when the SSP is going to happen. It's so difficult to actually predict when exactly SSP is going to happen. It can happen immediately after the measles resolve, or it can happen 10 to 20 years down the line, where you can have a patient that was developing normally beforehand, and then suddenly not walking, got weaknesses, got speech aphasia, got cognitive behavior dysfunction, behavior problem, and so on. So if you do the MRI will shows kind of like cortical sclerosis in the brain. If you do MRI, it's a progressive problem. It's not it's not going to bank you immediately. So normally you see progressively, slowly progressing SSP developing after the measles infection. So it's not immediately. Okay, so those are the most yang severe about measles. But what is the common complication that you see in measles?
Otitis media.
Okay, so it's a simple thing. Otitis media. Sometimes you can have pneumonia, pneumonitis. Sometimes you can have measles, meningitis as well. Okay. Because this is differential diagnosis. So Kawasaki, rubella, EBVs, Rosella, scarlet fever. So in this case, it's not Kawasaki because there's few things that does not really features in this case, and plus this case, this boy has a lot of runny nose as well. Why it's not rubella? Because rubella tend to be much more milder, and then the rubella tend to have occipital lymphadenopathies. Why it's not EBVs? You know, it could be EBVs, but the EBVs rashes does not really behave like that. It tend to be all over. It tend to be on the trunk rather than behind the ears. And then EBV, you expect them to have lymphadenopathies. You expect them to have a bit of more hepatomegaly. Rosellas, as I mentioned before, the rush tend to happen at the end once the fever start to get better. And scarlet fever, it tend to be more tonsillitis and pharyngitis than anything else. Okay, so as you guys rightly says, this is measles. The history is very typical, especially the catheteral prodrome, the fever, the conjunctivitis, the cough and coryzal, and the rush tend to happen about 3 to 5 days later after the start of fever, after the start of the cough, coryzal, and also conjunctivitis. Complete spots is the spots, the whitish spot that you see in the buccal mucosas. It's very pathognomonic. So if you see them, it's likely to be measles, not anything else. The problem with complete spot is it basically disappear as soon as it's appear. So maknanya dia boleh hilang almost immediately within 24 hours. So as soon as you see it, you know this is measles. The thing is, if you don't see it, it does not mean that it is not measles. And obviously the maculopapular kind of rash that started from behind the ears, spread into face, and also kind of like coalescing to the bodies. And usually the child looks very miserable, because it's not nice to have measles. The complication of measles, you can have pneumonia. Something can have a bit of ulceration of the cornea because of the conjunctivitis. So sometimes people just keep rubbing the eyes, and it can cause injury to the cornea. You can have otitis media. Sometimes the measles stays in your epithelial guts that make your epithelial guts become more inflamed, producing a lot more mucus, so that you can have acute gastroenteritis because of that. And obviously, if your child looks very, less than 6 years old, high fever can cause febrile convulsions. And very rare, it causes encephalitis, and also SSP also quite rare as well. But as I mentioned before, it can happen 10 to 20 years down the line. Okay, so
Doctor, I have a question. For infectious stage for measles, it mentioned that 1 or 2 days prior to rash and 6 days after. So after the 6 days, it is considered not infectious.
Dia macam apa, dia panggil viral loading kan. So the infectious period, mana masa yang virus dia paling banyak dalam badan dia, couple of 2-3 days before the rash appear, and then once the rash disappear, or once the fever disappear, ataupun the fever dah subsided, normally it takes another 1 week after that. So your infectious period is only about 10 to 14 days. So meaning that the even though you got better with the viruses, but the virus is still in there, that you can spread to other people. So it does not mean that once the fever subsided, once the rashes start to improve and disappearing, it does not mean that the viruses are also gone. The virus is still there. Cuma your body already recovered from the viruses. Sama macam COVID kan. So COVID, your incubation period is probably about 2 weeks, but it doesn't mean that after 2 weeks your viruses already disappeared. The virus is still in there. Cuma your body already developed the immunity against the viruses. So you won't have any more symptom, but you still carrying the viruses after that. So your infectivity index, your infectivity power is still there despite you not have any fever or not.
So Doctor, the isolation period for this
Isolation period normally we say up to 2 weeks lah. Cuma up to 2 weeks tu from the start of the rash. So those are your isolation period. So 14 days from the rash started. Okay. So the take-home message, measles now is coming more and more, not just in the UK. It's also in Malaysia as well, especially around Philippines and also around the Sabah Sarawak area. Recently, we have a cluster of measles death in Kuala Koh, orang asli punya area dekat Kelantan. So that's probably due to the non-vaccinations punya groups. And measles punya typical catarrhal rash, catarrhal phase before the onset of the rash, and the rash starting from behind the eye, behind the ears, around the hairlines, spreading downwards. And if you suspect this measles, if you suspect, not confirm, if you suspect je, if you just suspect them, you need to notify the public health ataupun Jabatan Kesihatan Negeri lah, if you suspect measles. Okay, so no question about case number 1, eh? Okay, if there's no question, then we go for the second case. So I'm just going to stop here, stop sharing. Okay, right. Siapa nak present? Afiq? Orang lain?
Ni Doctor.
Who's there? Knock knock. Who's there?
Doctor.
Okay. Okay, fine. Right.
Okay, for the second case. So, Cindy is an 11-year-old girl referred to pediatric outpatients by her GP. The letter says, "Thank you for seeing this girl who has had her first fit. 3 weeks ago, she was at school when the fire alarm went off unexpectedly. She felt pain and clammy. Friends tried to help her to walk out of the classroom, but after about a minute, she collapsed to the floor and had a brief episode of jerky movements affecting all 4 limbs. There was no incontinence or thumb beating. She regained consciousness within a minute, but continued to feel weak for a few hours afterwards. Cindy had a febrile convulsions at 18 months of age, and she has fainted on about 5 occasions, mostly in emotional situations or when it has been hot. She described herself as an anxious girl and has a sensation of heart rate racing every few weeks. She has never been in hospital but has seen GP for her heavy periods. There is no family history of epilepsy, but her aunt collapsed and died at the age of 28 in Kelang. She is top of her year at school and hopes to be a doctor or lawyer." Okay, so from this case, what are the important keywords that you guys can point it out? Can anyone? Can Merizwan pointed out any important keywords in this case? Hello, anybody home?
11-year-old.
Okay, 11-year-old girl. Anything? Okay, so it's okay. So basically, let us just summarize this case. So in this case, is it cases of the seizure or syncope? What do you think, Rizwan? Anyone else? Aina Atira?
Seizure. I think this is a seizure case because
Oh,
there is jerky movement.
okay.
Okay. And she had history of febrile convulsion before.
Okay, so jerky movement and history of febrile convulsion before. Okay, any other person wants to, apa? Is it a syncope or seizure? Or just anyone agree with Aina?
I think it's possible also for syncope because patient has palpitation and also has family history of her aunt had sudden death at 28 years old. So it can be due to cardiac syncope.
Okay, good. Okay, so Adha, can you explain? Can you
Okay, yes.
explain the difference between seizure and syncope?
Okay, I try. Okay,
Related to this case.
okay. In relation to this case, if we take a look at seizure, usually if seizure they are unprovoked, but in syncope they must be triggers that cause this patient to have something. So I think like the trigger for this patient is the situation itself, like there are fire alarm, and then there is hot environment and some she also have an occasion of pain due to hot environment, emotional situation. So I think the triggers is there. So I think it's syncope, the difference lah.
Okay, good. Another?
And then another thing is this patient, she collapsed after 1 minute and regain consciousness within 1 minute but continuously feel weak. If seizure, it takes time for it to regain the consciousness. But terbalik. If in syncope, it will take time in order to collapse, and it immediately regain consciousness. But in seizure,
Okay.
betul ke? In seizure,
in syncope you can faint it immediately. You don't take time to faint it.
oh yeah. Okay, in syncope it takes time. It does not take time to collapse, but and it regain consciousness immediately.
Okay.
So I'm just going to interrupt here. So from the description of the event, the other event here, event here, she felt faint and then and then clammy. She tried to walk out the classroom, and about a minute, but after about a minute, she collapsed to the floor. She had a brief episode of jerking movements affecting all 4 limbs. She has no tongue biting. She has no incontinence. She regained consciousness within a minute, but she feel weak for a few hours afterwards. Okay, the question now is this epileptic or non-epileptic seizure? Does it sound like a seizure to you? The jerking movement, the fainting, the collapse, the feeling of weakness after that. Does it look like a seizure?
Okay.
I think this is non-epileptic.
I think it's syncope because there's no tongue biting.
You guys need to know, people use the word seizure freely. Maknanya, mana the word seizure ni, obviously the medical term of seizure is a misfiring of your neuron in the brain. But the word seizure, if you by the layman person, the seizure could be anything. It could be collapse, could be orang kata kalau orang Kelantan dia akan cakap nyetok lah, terik lah, and so on. So many things kan. So the word seizure itself if people say it's seizure, it does not mean that the seizures mean that the epilepsy. Okay, so that's why it's always things that
Need to clarify.
term yang kita pakai adalah, is it does the description that been given to us, you need to decide whether this is epileptic seizure or non-epileptic seizure. Collapse could be a seizure, but it is not epileptic seizure. Faham tak?
Oh, okay. I think it's a non-epileptic seizure lah, like that.
You think it's non-epileptic seizures?
I think.
You think. Okay. What's your name?
My humble opinion.
Okay. So carry on Azatul, carry on.
Yeah, okay. If you think this is a case of syncope as compared to seizure, so what are the differential or the diagnosis that you guys can give? You guys can suggest of? Because we have many causes of the syncope. So can I have Zaki? Zaki?
Yes.
Okay. So what do you think, if this is the case of the syncope, what are you think the diagnosis of this patient? Because syncope, it comes with many causes.
That's very easy. Yeah.
As you can see
Can
in the
be-
case, he fainted because of
Can
the emotional.
be cardiovascular or it can be due to psychogenic causes.
Sorry, after this?
Maybe psychogenic.
Apa dia?
Psychogenic.
Psychogenic, okay, it can be psychogenic. So why you said so?
Uh, 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 because she faint after she heard the fire alarm, so she might be shocked, and also she also describes herself as an anxious girl, so it might be triggered her to faint.
Okay, thank you, Zaki. Psychogenic is also one of the causes of the syncope because, as you can see, when the patient collapsed after hearing of the fire alarm went off unexpectedly. So it may be because of the frighting. It caused the BP to drop and rapid breathing and causing reduce in cerebral blood flow. Okay. Thank you, Zaki. Another person can give another diagnosis. Can I have Sharafina?
Maybe cardiac related, like arrhythmia, because it was stated that her heart was racing every few weeks, and also she felt faint and clammy.
Okay, good. Yes, cardiac syncope also can be the one of the differential diagnosis in this case. And another important history for the cardiac syncope is that her aunt collapsed and died at the age of 28 because cardiac syncope is it can cause sudden cardiac death. Okay, thank you, Sharafina. And can I have another way? Can I have Fatni?
Orthostatic.
Okay, orthostatic. Why is it so?
Because prolonged standing, it can be triggered by prolonged standing.
He has history of.
Okay, prolonged standing. So it might be because of the and then the patient has history of fainted because of the heart situation, right? Maybe
Heat
because of
situation.
dehydration kan? Dehydration. So dehydration can cause hypovolemia and cause orthostatic hypertension. Okay. From the history, what are the further questions that you want to ask to rule out the diagnosis that have been given by our friends, such as cyclogenic for cardiac syncope or for the orthostatic. So what are the further questions that you want to ask?
Okay, for cardiac causes, you can ask if she has been diagnosed any cardiac problem
Okay,
during,
good.
then we can
Like
Okay.
if like maybe there are certain situation previously that very related to the syncope history of this patient, macam dulu dia pernah berkawat, lepas tu dia pengsan upon berkawat ke, her history, something like that. And what happened before syncope, during syncope and after the syncope
Okay.
throughout the scenario.
Okay. Do you guys think the posture of the patient during the syncopal attack is important?
yes, yes.
Why?
Because in like orthostatic syncope, it could be the difference, the reflex, they have inadequate reflex of blood control to control the blood pressure as the patient move from the transition of supine to standing upward. So the differences in pressure is like 20 millimeter mercury difference systole in the systole.
Systolic.
Yeah, the
Okay.
reflex is not adequate.
Okay. In the case of the cardiac syncope, what are the postural for the patient? If in the orthostatic syncope, it is in the upright posture. For the cardiac syncope, how can we differentiate the cardiac syncope and the orthostatic syncope of other syncope?
I'm not sure.
Okay, so basically in the cardiac syncope, the body positions occur in a sitting position or recumbent position. All right. So another diagnosis that you guys can give instead of psychogenic or cardiac syncope or orthostatic syncope is vasovagal syncope. Does anyone have an idea regarding the vasovagal syncope? Does you get anyone? Faiz, do you have any idea regarding the vasovagal syncope? Faiz, are you there? Or anyone else
The
can help
syncope
Faiz?
usually
Ah,
is precipitated by fear or any
okay,
emotional stress or
okay,
pain.
okay. Okay, so in these cases, what are the history that's suggestive of vasovagal syncope?
The fire alarm went off unexpectedly, so she probably that might trigger fear to her.
Okay, what about the age?
Sorry?
What about the age of this patient?
Oh, 11.
Mm.
Oh,
Is it
common in
common
young.
in the,
Yeah.
okay, common? Then another history that's suggestive of vasovagal? What about the pre-syncopal symptoms in the vasovagal syndrome, in the vasovagal syncope?
Fin, felt faint and clammy.
Okay, yes. So, why this patient, dah bertanya tak lah. Okay. Lagi.
I was thinking
What
about
about the jerky movement? Yeah, Aina? What were you thinking about? What
I
are you
was thinking
thinking
about
about?
previous fainting episode,
Okay.
and it is said that she has fainted 5 occasions. Is it is she having was she having the same fainting episode? I mean jerky movement during that fainting episode.
Okay, so it can be asked.
Okay.
So kalau in the case of the vasovagal syncope, and because of the seizure, how can we differentiate the jerking duration? In syncope and seizure, dia punya jerking movement tu macam mana beza? Dia punya in terms of duration. Duration of jerking movement in the case of the syncope as compared to seizure.
For seizure, the jerking movement. I try. Can I try?
Okay. Yeah. Sure.
For seizure, maybe the jerking movement lasted for a few 30 to 60 seconds. But for syncope, less than 15 seconds.
Okay, good. Yes. Correct, Awati. Okay. I was thinking about apa tu? She was an anxious girl and she has a palpitation and heavy period. I think of hyperthyroidism. So do you guys agree with me or do you not agree?
I agree. It could be. Because patient have menorrhagia and palpitation, racing, and she is an anxiety girl.
Wow.
Anxious girl.
Yeah. Okay. Okay, so how can this hyperthyroidism are related to the syncope?
Maybe related to cardiac syncope.
How it can cause cardiac syncope?
Due to arrhythmia.
Yes, correct. Okay, so basically, in the case of the hyperthyroidism, it can cause abdominal heart rhythm and it can cause arrhythmia. So arrhythmia is one of the causes of the cardiac syncope. So that's how the hyperthyroidism are related to the syncope. Okay. Another further history that you want to ask. For the case of pregnant suggestive orthostatic hypertension or orthostatic syncope, right? So what are the further questions that you want to ask? What are the further questions that you want to ask?
Orthostatic.
Yes.
Is there any long-standing? Or any blood loss? Any blood loss? Vomiting, diarrhea, hypobol.
Okay.
Anemia of chronic disease.
Okay. Such as?
Such as. Such as maybe she had malignancy or.
Okay. Do you guys think drug history is important in this case?
Yes.
What are the example of the drug which is can contribute to the syncope?
Vasodilators, diuretics, PRB.
Diuretic. Okay. Why diuretic?
Because it can cause hypovolemia.
Okay. It can alter the electrolyte. Okay, because electrolyte also can cause syncope. Any other drug?
Antidepressant.
Sorry, Zaki?
Antidepressant.
Antidepressant, good. Okay, how antidepressant can lead to syncope? It's important in the case of the syncope.
I'm not sure.
Okay, because antidepressant, for example, like tricyclic antidepressant, it will cause prolonged QT interval. So prolonged QT can be associated with the arrhythmia, so which is one of the causes of the cardiac syncope. Okay, for the cardiac syncope, any other history that you want to ask instead of underlying cardiac disease set of positions. So what are the important questions that you want to ask to rule out the diagnosis?
If there is any history of shortness of breath, edema, chest pain.
Okay. Also, you want to ask any other cardiac symptoms in this patient?
Yes.
Okay. Another history that you could ask for the cardiac syncope is that is there any injury during the syncope because it's suggestive of cardiac syncope. Yeah. So any questions secondly?
Are we still?
Yeah.
Sorry. Kinda sorry. I want to ask
Yeah.
how injury related to cardiac syncope.
Answer. I'm not sure how the mechanism it can cause injury, but I think it is tak tahu. Tak sure. Doktor tak tahu. Doktor tolong.
Apa injury apa?
Macam mana? Kenapa saya ada jumpa dekat dalam buku teks yang cakap injury berlaku masa syncope associated with the cardiac syncope. Tapi kenapa?
Well, so it's not just for the cardiac syncope. It's for any syncope. If you really loss of your consciousness, if you fall, then you should have an injury, kan? If you got a seizure, like if you're walking and then you got a seizure while you're walking, we expect you to basically collapse as well and fall and have a fall. So you might have hit your head with atau bucu meja ke onto the floor and so on. So you expect kind of an injury happen. So if you got a fall or a collapse but no injury, then you are thinking about psychogenic seizures ataupun psychogenic pseudo seizures normally. So those are the difference. And normally kalau dia ada multiple collapse all the time but never had any injury at all, even daripada dia berdiri sampai dia jatuh, have no seizures at all, has no injury at all, then you suspect that this child has not got a seizure ataupun epileptic fit. It tend to be pseudo seizure, which is psychogenic, macam buat-buat lah basically, due to possible psychological disorder. But if you got cardiac injury, cardiac syncope, you can have multiple falls due to the cardiac arrhythmia, and then you expect mana those are the things that you can't control. If you can control your falls, macam korang berlakon TV kan, tiba-tiba tiba nak rasa macam nak pingsan, nak jatuh kan, drama TV pukul 7 ke pukul 8 ke pukul 9 ya. So those are the falls that the psychogenic pseudo seizure normally has, mana dia jatuh without any injuries. Anyway, I'm going to stop you there lah. So from this case, you guys need to make sure, you guys need to agree, is this epileptic or non-epileptic seizure? So if you think this is epileptic seizure, then the main thing that you want to know is, does the child has all those 3 epileptic phases, which is pre-ictal, ictal, and also post-ictal states. So the pre-ictal in this case is the fire alarm went off unexpectedly. She felt faint, and then she tried to walk out of the classroom, and after a minute, she basically collapsed. So the collapse, starting from her collapse with brief episode of jerking movement, affecting her all volume. So those are the ictal states. So the pre-ictal is the fire alarms went off, felt faint and clammy, and then she tried to walk out. Okay, and then the ictal state is she basically collapsed and have a brief jerking movement of all 4 limbs. Okay, and then the post-ictal state is that she regained consciousness within a minute. However, she feel very weak for a few hours. Okay, so those are the 3 things that you need to know, whether the pre-ictal, ictal, and also post-ictal phase. What happened? Apa dia punya description in that case. the clue here, the hint here is she recovered immediately, almost immediately. Cuma she feel weak for a few hours afterwards. So this actually pointing out not really a neurological seizures. It tend to be some other causes of the seizures. Okay, so that's one thing. The history of febrile convulsion for 18 months of age, fainted about 5 times occasional, mostly emotional situation or with the hot environments, anxious girl sensation of heart racing. So this is all giving you all hints that this is not really epileptic punya seizure. It tend to be other causes of the seizure. So this is a provoked seizures. Okay. And there's family history of auntie the collapse at the age of 28 and died. So this also putting out this is probably cardiogenic seizure that you need to think about. Okay, so the other thing about psychogenic seizure, satu dia tak ada injury, yang kedua it tend to happen with audience. It does not happen when they are alone. So kalau orang yang ada psychogenic seizure ni ataupun pseudo seizure, the seizures normally happen in front of people. It does not happen when they are alone. So those are the main thing about pseudo seizure ataupun psychogenic seizures. Okay, let me try to share my slide. Okay, so this is dia punya apa tu, physical finding, which is nothing much really. So she's a tall girl, 95th centile, sorry 91st centile. Her weight is about 53 kilograms, which is not too bad, and the rest of examination are normal. So if you got somebody who collapsed, so what is the thing that you want to do in terms of investigation point of view? What is the investigation you want to do?
ECG, Doctor.
So you want to do ECG because of that. Because that you want to make sure this is not really cardiogenic causes. Okay, cardiac cause. Okay, what other thing you want to do?
For blood count, for the hemoglobin level.
Okay,
because of the hypovolemia. Okay,
so basically, if she got menorrhagia, so she might have anemia. So because of that, she probably has cardiac stress because of that, or sometimes because of the hypertension due to low HbN. Okay, so other thing you want to do?
Renal profile to look for dehydration based on urea creatinine.
Okay, all right. Okay, what else?
Thyroid function test to rule out hyperthyroidism.
Okay. Hypothyroidism. Okay. Anything else?
Echocardiography if there is abnormalities in the ECG.
Okay, okay. And are the urgent thing that you want to do first?
Tilt table test.
That's not urgent. Apa benda yang urgent?
EEG.
EEG is not urgent as well. You don't diagnose seizure or epilepsy with EEG. Epilepsy is diagnosed clinically. Clinical diagnosis. You don't need EEG to diagnose an epilepsy.
MRI. CT scan. MRI of the brain.
Imaging.
Apa tu? Imaging.
CT scan or MRI of the brain.
Wow, it's not urgent. Is it urgent?
Not urgent. Oh, glucose.
Yes, glucose. So those are the things that you want to do. If the child got low blood sugar, hypoglycemia, then it's easy corrected by just giving dia punya apa, bagi dia makan apa, vitagen ke, makan roti ke, pisang and so on. So it's so important to check. The two things that you want to check when you got somebody collapse. Collapse means that any collapse, not just seizure collapse, any collapse. So two things, ECG and also blood sugar. Okay. Kalau dia ada arrhythmia at that time, then kalau dia VTs ke SVTs ke, then important to get treatment straight away. If they got hypoglycemia, then need to be treated immediately as well. So Okay, plausible causes of collapse. So this is the possible causes. So it could be a seizure, it could be a cardiac arrhythmia, it could be a vasovagal syncope, it could be panic attack, breath holding attack at this age, 11 years old, probably not really the thing. Reflex anoxic seizure, normally in children, but younger children as well, and pseudo seizures, as I mentioned, about psychological disorders, and then other causes, as I mentioned, about hypoglycemia. Okay, so in this case, as I mentioned before, it's probably arrhythmia that caused her to collapse, or she might have panic attack as well. So it could be two things. Maybe that she stand up in its mana dia duduk dalam classroom, tiba dia stand up, so it could be also the vasovagal punya syncope as well. The thing is, the vasovagal, the cardiac arrhythmia, the panic attack, when they collapse, they can look like a seizure. They can have a brief jerky movements because they have hypoperfusions, or dipanggil transient hypoxic insult, and that probably reduce the blood pressure to the brain, reduce the blood supply to the brain. So sometimes because of this, the brain can collapse, and then they can have a bit of brief jerky movement because of that hypoperfusion insults. Okay. The main thing about this case is it terminated very quickly, and then she basically regained consciousness immediately after she collapsed, which means that it's not really an epileptic seizure. It could be something else. Okay. The most important thing in this case is you want to do ECG. Okay, and EEG is not really very helpful in this particular case. So I got an ECG for you to see, and I want you to give me the heart rate, and I want you to calculate the QTC intervals. Okay, Aizatul. All right, what's the heart rate and what's the QTC? The question is not for you, but you can always divert the question to your preferable or favorite colleague if you want.
Okay, can I have Sharvina to calculate the heart rate for this patient?
Um, 75 to 80 beats per minute. 300 divided by 4. 1, 2, 3, 4.
Okay, so 300 divided by 4 and that. Okay, that's fine. So that's about 75, 80. Okay, so what's the QTC?
QT interval, okay. Afiq, what is the QT interval? Afiq Syahrik.
Ya, tengah kira.
Take your time, take your time.
Mentang-mentang lah dia disuruh orang kira, dia take time.
Apa? QT.
I'm talking about calculate QT, QTC, calculated QT intervals. You guys know how to calculate QTC?
No, doktor.
Oh, tak tahu.
Tak tahu, doktor. Tak tahu.
So the calculated QTC, you guys should know this from the medical punya ni posting. So who's your cardiologist in medical punya posting?
Ada, doktor.
Tak ada.
Tak ada.
Oh, okay. So the QTC is the QT intervals divided by square root of RR intervals. So you need to firstly calculate the QT punya intervals. QT punya. So you need to see the Q. I don't know. Can you see my cursor?
Yes.
Okay. So you need to get the QT. Ni adalah Q, ni R, ni S, and then this is the T wave. So the QT is the Q to the T, which is here. So calculate dia punya interval dia dari sini sampailah ke sini. Okay, so that's about 1, 2, 3, 4, 9, 10, 11 lebih kurang. About 11, 12 kan, lebih kurang. So that's your QT kan. And the RR is dari sini sampai ke sini. So berapa dia punya RR itu?
75.
4
Box
4 boxes.
4 boxes. 4 boxes. 4 boxes times 5, which is 20 boxes. 20 small boxes. 20 small boxes times 0.04. So that will be 0.8 kan. So dia punya RR intervals is 0.8 seconds. Okay. So dapat yang QT ni ada apa? Ada berapa tadi?
11.
Dalam 11. So 11 times 0.04 is going to be 0.44 punya apa? 0.44. So the formula for QTC is the QT divided by the square root of RR intervals. So you need to know the square root of RR, which is 0.8 punya square root. Okay, so by doing that, then you got the QT punya interval, which is 0.44. 0.4 divided by the square root of 0.8.
Or 9. 0.
Dapat?
0.49.
0.49.
0.49. Okay, 0.49. So now so you got the value of 0.49. So you need to know what is the normal value for QTC. Okay, so I show you the normal value for QTC. Okay, so the QTC, the corrected QT is QT intervals divided by the square root. Sorry, tak nampak pula dia punya square root ni. Square root of RR interval. So the QTC normally 0.41 ataupun less than 0.45. So in this case, I don't know macam mana dia orang kira sampai 0.52. Rasanya mungkin dia ambil 12 dia punya QT tu 12 boxes kot. I think dia ambil QT interval to 12 boxes, so it's going to be 0.48 divided by the square root of 0.8. So that's why they come up with a 0.52. But kalau if you get the 11 pun, so it's still prolonged at 0.49. It's still prolonged because your QTC in children should be less than 0.45 seconds. So in this case, this child has prolonged QT syndromes. Okay tak? Faham ke?
Faham.
Okay, so because of the prolonged QT syndromes, it is a well-known case that can cause sudden arrhythmia ataupun arrhythmia. So that's why this child, this girl has been having dia punya history dia kata has been having a sensation of her heart racing every few weeks. So she's been having palpitations for almost every week because of these QT syndromes. And then because of the arrhythmia, so you can have sudden death because of this. So this child needs treatment. This child needs anti-arrhythmic medication, or this child might need pacemaker ataupun implantable cardiac pacemaker. Okay, so the thing about this case, obviously the fainting children, fainting teenagers is very common. Especially in girls, especially when they're hitting their puberties or ataupun dia start ada menarche. So it's very common in girls, especially when they are very slim girls, so tall and slim. Very common for them to have vasovagal ataupun mainly vasovagal syncope. It's not truly, not all of them are organic causes. Not all of them due to cardiac or due to neurological causes. Some of them is just psychological. So you need to make sure that you differentiate between those two. So as I mentioned before, pseudo seizures tend to happen with audience. It does not happen without audience. And pseudo seizures normally, once they collapse, they don't really have injury. However, with the cardiogenic syncope, neurological syncope, vasovagal, they tend to have injury when they collapse. And it's very important that everyone who has seizures, you want to make sure that they do ECGs and also blood sugars. And obviously RP, calcium, magnesium, other electrolytes, and so on. And obviously, if they have any sign of kita panggil neurological signs, then they need to have urgent CTs. Ataupun if they have, we call it focal seizures, one-sided seizures only, then you need to have urgent imaging, either CT or MRI. Okay.
Doctor, I want to ask. So for this patient, she has a prolonged QT syndrome. So does it always being diagnosed at this age or masa baby kecil?
So they tend to happen early on. Mana it can happen on occasional, very occasionally when they are small, probably less than 8 years old, they might have arrhythmia. Tapi this QT syndrome tend to happen more prominent, mana banyak kali and recognizable when they are bigger, especially when they hit the puberty. So kalau girls when they hit the menarche, kalau boys when they hit the puberty period. So it tend to happen around teenage age. However, it can also happen when they are small as well. Cuma dia punya symptom dia not that recognizable because a 3 years old won't be able to tell you whether they got palpitation or not. Okay, so kita panggil typically prolonged QT syndrome tend to happen in teenagers. The symptoms start to happen there because they start to recognize they got palpitation. They start to recognize they have a bit of a kind of dizziness, probably a bit of nausea as well because of the palpitation that they have. So it tend to happen more in the teenagers, but because they start to realize this is the symptom that they have. When they are small, they probably can feel it, but they're not be able to tell you or not be able to describe to you the feeling when prior to the collapse. So it can happen early on. Cuma normally the symptom is not really very obvious masa umur dia kecil-kecil lah. So it tend to happen about around teenagers time. Okay. Any other question?
Doctor, is prolonged QT syndrome congenital or acquired?
Difficult to say. I believe they are congenital. They are genetic component that cause prolonged QT syndromes. So kalau Google memang akan adalah genetik yang associated with the prolonged QT syndrome. Cuma it start to kick in. The symptoms start to kick in later, not during the baby period. It tend to happen later on. So that's why it probably happen when they are small. Cuma it's not as severe because normally kids don't really because kids punya heart rate normally quite fast compared to adult anyway. So in terms of their BP function, their heart function is still quite well at the time. But when it comes to of teenagers, this arrhythmia affecting their BP function. So that's why they got more episode of collapse because of this. But it tend to be congenital because it is a genetic. It tend to be genetic condition, not really something that you acquire. If you Google, I think there's multiple types of prolonged QT syndrome. But I think for the purpose of your learning, just remember there is a condition called prolonged QT syndrome that can cause arrhythmia. kalau nak belajar lebih lanjut, kena belajar dengan cardiologist about prolonged QT syndrome. Okay. Any other question? No? Okay, so if there's no question, then I think that's all. Kau tak ada question lain?
Doktor.
Hmm.
Sorry. Last question. Last question.
Okay.
Doktor, nak tanya kalau non-epileptic seizure dia ada treatment ke? Ke kita
Non-
buang trigger?
So basically, non-epileptic, you need to know the causes of them. Kalau dia cardiogenic causes, then you need to treat the causes. Kalau dia infection, then you need to treat the infection. Kalau dia macam macam psychogenic, then you need to refer to psychologist ke and so on. So kalau dia macam panic attack, then you need to teach them the breathing punya technique, calming down technique and so on. So those are the mana you need to find the causes of that. Okay, kalau dia hypoglycemia, then you need to treat the hypoglycemia. So treat the underlying causes. Macam for me kan, when I listen to a lecture by students, I might have a bit of absence epilepsy kan. So normally what I do is I just take a coffee so that I don't really sleep. Joking. Okay, faham right? So you need to find the causes for non-epileptic seizures. So there is a combo of three students in one laptop. Okay, so that's it. Boleh tak? Okay. Okay, fine. Alright.
Okay,
So if there is no question, I think this is your last session. Your last session for the long case. But I think that there's a few more seminar that I need to do with you guys. Obviously, the only platform I have now is the online platform for seminars anyway. Because I'm not really in Kuantan lah. I'm working somewhere else. But that's fine. So thank you very much for attending this session. We can adjourn the session with tasbih for us. Right, thank you very much. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Doktor.
Thank you, Doktor.
Doktor.
Thank you.
Thank you.